get started. Frank,
we are ready.
Here, yes. Wonderful. Okay, so Doris, I will turn it over to you to start the session and to introduce our featured speakers.
Fantastic. And I am going to introduce all of the speakers at the same time. I'm going to do just highlights, some more spicy than others, because the bios you have in your own packages. So let me start with Associate Chief Justice Frank Morocco. And as I did one time to my premier, I'm going to do that to you, Frank, too. I apologize for saying we don't need the commission at one point, out of frustration when the Canadian Armed Forces already had put their report. I only want to say you are delivering in spades, really delivering in spades. And we appreciate your work immensely. Of course, we know the Associate Chief Justice from previous inquiries, and he did back then also fantastic work, and some of the recommendations were even put into place. So maybe we will be so lucky this time that all the recommendations that you put forward in a few days would be updated by government and by the health system. So Justice Morocco is a graduate of the University of Toronto Law School, appointed to the Superior Court of Justice on 2005. And in 2013, he was appointed as Associate Chief Justice to the Superior Court of Justice. Prior to the appointment, he was a partner in Growling Law for Henderson, and I think I will leave it at that. In the answering panel or the reaction panel will be Wendy Francis, and Wendy Francis is the chair of Family Council's Collaborative Alliance, a family caregiver. And all I want to say about Wendy is that she is one of the best prepared persons that can interview someone. She has interviewed me and others that I have seen her podcast for several times, and she always impresses me on how well prepared she is. So Justice, if she asks you one time that she wants to interview, you say yes, because she is the most generous and the most well-prepared podcaster that I know. Wendy Dunn, our colleague attending NP from Greenwood Court, and Knowledge Rest, I travel with that, Lodge. What I want to say to Wendy, more than reading her entire CV, is the tremendous work, Wendy, that you did being the nurse practitioner in the nursing home during the first and second wave, and also, quite frankly, just so you get ready on this third wave, because there are about 1,500 patients that will be transferred from hospitals within the next 10 days to the nursing homes. So it will be busy once again in nursing homes. And I know that you will lead the ship in a beautiful way, as you did already. Donna Duncan, CEO of Ontario Long-Term Care Association, a wonderful colleague of mine, counterpart in the association. Lisa Levin could not be today with us because they had a parallel event, so she sends her regrets. Donna and I have worked intensely together trying to push initiatives. Just so you know, Donna, I just asked Matt Anderson to redeploy at least 4,000 of the 4,500 care coordinators to nursing homes, given that they're transferring patients there, and that you don't, not just you, we don't have the resources in those homes. So that's with Donna. With my friend Shirley Sharkey, and I call her friend because she is, the most important thing is that she is a new grandma. So she joined the club. That's the most important thing. In addition to that, she is the CEO of St. Felice Healthcare and has driven that organization from a tiny organization to the mega powerhouse that is today. And I want to say, Shirley, that I did in the presentation of Matt Anderson, brought again the issue that 7,500 RNs, NPs, and RPNs are ready to roll out vaccines, and that all that we are waiting actually is for the vaccines, because their organizations, their infrastructure, and their nurses are ready to help both in homebound patients, but go to warehouses, do pop-up clinics, etc., and that we shouldn't continue to wait because the situation is dire. So with that, I leave the mic to you, Frank, to share with us your thoughts. I already see the first slide. That is a good slide. We need to ask permission to use it. And please, you have here close to 300 colleagues eager to hear what can you let us know. Now, I do need to tell people that you cannot video record the session. We are video recording the session. And the reason being is that the report from Justice Morocco will be coming soon out to the minister, and we don't want him to get in trouble ever. So please do know that we will post the recording as soon as that report is out. The recording of this session will be out. But you can tweet your excitement that he's with us. You can tweet that he's sharing. Just don't quote him. And if you do, it's not mea culpa, Frank. I said it.
Okay. Well, if Doris, if you want me to start now, then I will. First of all, thank you for the invitation. That's very much appreciated. It's an opportunity for me to get out from behind the commission and see what people really want to tell me. Secondly, thank you for the submission you made, and actually more than one really, because I did read some of the publications, and it's been very helpful to us. As Doris indicated, we haven't reported yet, and so I have to be a little careful because we're supposed to report to the minister, and we will report to the minister. And she shouldn't be finding out about the report after you find out about it. That would not be appropriate. And so I have to be a little careful in what I say. A couple things, though, a few things really. First of all, what we were doing was quite unusual in terms of inquiries. Most times something has happened which has upset people, and the government, in an effort to clear the air after the problem has presented itself, and after whatever it is that's disquieting has occurred and is over, the government appoints a commission to in part inform the people, the public, about what happened, and secondly, the commission makes recommendations. What we're doing is quite unique because we were called into existence, if you like, in the middle of something. As you know better than I do, really, and it's still going on. I must say, I thought in July, the end of July, the beginning of August, that by now things might have settled down, but as we all know, that wasn't exactly the virus's plan for everybody, and so things have not settled down. But it creates an odd situation because you're reporting about something that is still happening. And so, for example, you can think, well, there's now a vaccine, they've discovered a vaccine. Well, then there's all the problems and everything we've been reading about the vaccines and so on. So you have to be careful in that situation because you don't know everything. Not that you ever do, but you really, truly don't know everything. And it is unfolding as you sit here. So That's the first thing. Secondly, we have a very short time frame as these things go. Typically, a commission of inquiry could take 2 to 3 years. Now, nobody expected that, given that we were in the middle of something, that we would have the luxury of that much time. But April the 30th is a short time frame. And just let me try to make that live for you for a minute. During the course of the commission's interviews and investigation, we heard from over 700 witnesses. Now, we didn't hear from them individually. On occasion, we heard from them as a group. But still, it's 700 people. We created 15,000 pages of transcript. Over 300 written submissions. And then on top of that, we have to write a report that will probably exceed 300 pages, and do that by April 30th. So that's the nature of our remit. That's what we had to deal with. There's a risk in all this, and the risk is that you think of this as policy, and we have a dry discussion about policy. And I don't mean in any way to downplay the significance of the issues, but you know, it's one thing to read the basic guarantee, for example, and to see very thoughtfully presented why you need so much time for registered nurses, so much time for RPNs, so much time for PSWs. And you read that, and then you can have a discussion with someone about that and so on. And that's fine, but that's at a paper level. That's at an intellectual level, if you like. To me, what made a difference that I can't put a value on, really, were the interviews. The interviews with staff, which included members of your association, the interviews with families, and the interviews with the residents. But it was the interviews with the staff, because when people describe the pressure that they're under, when nurses, and we interviewed some people confidentially. We did that. I should have probably said that when I was outlining our process. But we did interview some people confidentially. And so when you talk to a registered professional, a nurse, and he or she says, listen, I had responsibilities for supervising, but I didn't have the time. Our staffing was not right. I didn't have the time. I couldn't supervise properly. I understand, and you can see the effect that had on the individual. When you talk to them about their experiences with the people who died, and trying to help those people at the end of their life because their families weren't there. It changes your perspective. Prior to that, it might have been a discussion around communication. Oh, there should be good communication. There should be better communication. But then when somebody describes to you what it's like to be the only person that somebody is seeing in the last moments of their life, you know, you start to say, you know, communication's actually very important. This is not some aspiration. This is something that we need to work on. So the strategy, if you like, of interviewing real live people, in a sense, getting an oral history of the people who actually lived through it. It really humanizes what we're about, and I think it's been enormously helpful, and I know you assisted to some extent with that, but I want to tell you that that was something. When I was counsel of the province during the Walkerton inquiry, I knew that the commissioner had met with the families, that because 6 people died. There was a 7th person, but there was some question about why they died, the cause of death. But I remember Commissioner O'Connor saying that this was a very important thing he did, but it hadn't really registered with me. The significance of it hadn't registered until I started to live through it myself, and I quite frankly won't forget it. But so that hopefully grounded us in reality. Now, we of course have to produce this report, and you all have to read it. And I dread Doris's criticism, which may come. My hope is that we don't elicit that kind of criticism. But I know in the end we have to put this report out there, and you all have to read it and see whether it makes any sense from your point of view. We did put out interim recommendations, as you know. It's a bit unusual for a commission to do that. Justice Campbell did it, and I knew him quite well, really. We weren't that close personally, but we did spend some time together. And I remember he was quite ill at the end, and I remember the extent to which he struggled to finish his report. And I don't know how many of you are familiar with it, but if you read through it or look at the executive summary, you read through some of his reasoning, you realize how smart a man he was, how much foresight he had, and you know, you would think you should pay attention to what he said. And as I say, for me, it kind of doubles down on me, because I remember how he was struggling at the end. He had an oxygen. He was a very tenacious character, but he had an oxygen tank that he needed, and so on. But he felt very strongly about his report, and he wanted to finish the final version. But he put out, the reason I mentioned him, he put out an interim report, and we kept it simple, but we reported twice. You know, it's a funny thing. You know people are getting sick, and you know people are dying, and you sort of say to yourself, well, we can't say nothing while all that's happening, and then issue a report long after that's over. That's just not good enough. So we did issue 2 sets of interim recommendations because we felt we should. I did make a couple of notes. One of the things that I was struck with, and I'm sure you have been struck by this too, is that in the middle of a pandemic, you have to resort to the expertise where it is. You don't have time to create a new structure and to duplicate expertise. And so, you know, when you think of the community where I live, there are a variety of organizations concerned with healthcare, whether it's home care or there's a local hospital. Michael Guerin is the hospital. You do realize that long-term care is part of that. At least it should be. And for some reason, it seems that we function in silos, and there's a tendency to want to duplicate in your area, like not you personally, but in one's area, healthcare expertise that already exists, and there really needs that's really a problem, because quite frankly, as a country, I don't think we have the capacity to produce 2 or 3 versions of the same thing and pay for it. Certainly not now, after the amount of money that we've had to spend on responding to the pandemic. It's the same situation, I think, that you get into when there's a war and you spend significant sums of money on the war. The money that you don't have, you have to do it. It's not about that. But that will have an effect later on. So we're not, as you look forward, the resources that we have in the community, there needs to be some integration of those resources. You're all well aware of the idea that you should age, people want to age at home. I certainly can tell you I fall into that category. I don't want to be anyplace else. But you know, time passes, and so there needs to be a way of moving through the different stages of your life and the different kind of care that you need. There needs to be an orderly way of doing that, especially, you know, when you consider that at that age in your life, you're vulnerable. You can't look after yourself. It's kind of unfair, you know, when somebody challenges you to look after yourself and you say, well, I've kind of exhausted myself. I can't do it. So it strikes me, not so much as the chair of the commission, but as a citizen or a resident living in a part of the city, that there needs to be a way of moving through this process and accessing the supports that you need. I remember, you know, long-term care evokes, I think, this response in a lot of people. It doesn't me anyway. You know, I remember my mother, my dad died rather suddenly. Not, he was ill, but the illness got him faster than we thought it would. But my mother, I remember when she couldn't live on her own anymore, and she lived around the corner. I remember being worried that if she went into a retirement residence, that when she was too sick to be in the retirement residence, they would tell her she has to leave, and what would I do then? And so I had elaborate I'm sure they were glad to be rid of me at the end of it all, but I had elaborate discussions with them and wrote them lawyers' letters at the time, because I was a lawyer, outlining what they had agreed to. But what they said was, we will put the supports in place so that she can remain here for as long as necessary. Now, the corollary to that is I had to pay for it, and I was fortunate that I was able to do that. But that sort of transition should be able to happen in a relatively straightforward way, and that's a goal. I think that's important. it's strange in a way that, for example, I won't talk about our report, but let me talk about reports that you've written. Talking, for example, for the last, I don't know what, Doris, 15 years about the staffing shortage. It's strange that a problem from your perspective persists over that period of time. And in a circumstance where we're all going to be of an age where the state of long-term care may be important, even if we're not going to get through life that way, we have parents or aunts or uncles. We have this in common with everybody else. And so it's passing strange to me that you can observe a staffing shortage and be talking about it for 15 years in something that is as common an experience for all of us as it is. I don't pretend to understand why that is. It doesn't seem logical to me that it should be that way, but nevertheless, you know the what do you call them? Action alerts, reports that you've issued telling people that there's a problem in the staffing area.
You know them, and we didn't even copy them to you. You would have received thousands of them.
No, I know, no. I wouldn't have time to do anything else but read. No. But I am familiar with them. I found them helpful, but I'm not talking about my report. Anyway, those are some of the thoughts I had, and I think, Doris, if maybe people want to ask me some questions, maybe I should stop talking now.
I think, Frank, maybe we allow, if it's okay with you, for the respondents, very brief responses, and then questions for all.
Whatever way you want to do it.
Because I want to add to the comment about your mother. Very, very, very important experience that you had. The fact that the directive just came out from government, I'm not even sure, I'm sure Donna is aware of it, but likely other colleagues are not, where placement coordinators, as of a couple of days ago, can locate, as you know, I mentioned before that 1,500 patients, ALC patients, will be moved in the next 10 days from hospitals to nursing homes. The piece that I didn't mention, but is very apropos your concerns about your mother at the time, is that they can be moved to any nursing home available without the permission of the resident or the family. So just picture that desperation that people I don't think are even aware, but I have the directive in my hands. What's happening is unfathomable in nursing homes. It has not gotten better. My colleagues will share with you. And with this influx of new people that need the space, because we need space in the hospital, right? This is what we created. This didn't happen. It's not a natural disaster. That I'm afraid your commission may continue for the third wave and the impact in nursing homes. Maybe I open to our colleagues, and starting actually with a person that represents really families, Wendy Francis, and your experiences, and if you can bring your thoughts briefly, then Wendy Dunn, the nurse practitioner that works actually in a home and served as both, well, she will talk about that. Then Donna Duncan, my colleague in OLTC, the CEO of OLTC, and then Shirley, which I'm sure will bring the other side of the coin, I hope. That's why we ask her to join, that there is, of course, many times a need in nursing homes for spaces, but there is something called home. And they all should be looked equally in relationship to the lives of people when they age or when they need services. So first to you, Wendy.
Thank you so much. Good morning, everyone. And I just want to say thank you again to the Registered Nursing Association of Ontario for extending the invitation for the Family Council's Collaborative Alliance to speak on this panel and to provide some perspective of the essential family caregiver supporting residents in long-term care. So before I start, I just wanted to quote this one particular quote I came by. It says, "One person caring for another represents life's greatest value," by Jim Rohn. And unfortunately, during this pandemic, there was no value placed on the lives lived in long-term care settings. And in order to protect lives, it was at a cost of isolation, restricting essential family caregivers from visiting, and a lack of staff value that the work that they do in these particular environments. And I'll leave it to those panelists to speak on to those points. But I just wanted to say, in terms of long-term care in this province and in this country, it's like a piece of a puzzle, and we have to ensure that we look at the whole picture. But in order to get to that, we need to look inward and then look out, and the core needs to be the resident and their essential family caregiver, and then fan out from that in terms of their support. And this pandemic showed how extremely important that the essential family caregiver were, and that their lack of presence had on the resident, indicating their inability not to have security, familiarity, and of course the love and the support. There was one particular picture that I did receive during the early on in the pandemic, where the residents had lost extreme weight after 2 months of isolation and were barely recognizable. So there were many essential family caregivers that were not able to be with their loved ones during their last moments, and those were stolen during the pandemic. And I think there's just, in terms of some key takeaways that can be part of it and should be part of the re-imaging of long-term care going forward, is to ensure that essential family caregivers are not isolated from each other, from their loved ones in long-term care, and that the ministry provides clear directives that is understood by all. Because during this pandemic, with directive number 3, it wasn't clear at all facilities, and not all facilities acted the same way to allow essential family caregivers to come into the facilities. Even though this was implemented back in September of 2020, we know of many families that were not able to go in until October or November. And even if they did, it was just for a week or two. And it didn't matter if it was a for-profit facility, nonprofit facility, or a municipal facility, because at the end of the day, it's each administrator that decides at each particular facility, not if it's a for-profit, non-for-profit, or municipal. And the essential family caregiver, once they were allowed in, noticed significant changes in their loved ones, whether it was mental decline, withdrawal, or loss of behavior. And they had to reestablish all of those conditions just to even gain back a baseline, maybe not as same as before, but at least to reestablish that connection again. And secondly, there needs to be a clear definition of the essential family caregiver, because if we have the resident at the core of this particular puzzle, it needs to be clearly defined. And during the pandemic, the essential family caregiver was just viewed as a visitor, and basically a non-important person to the resident, which should not happen moving forward. And I know that the RNAO was definitely one of the champions to ensure that families got reunited during this pandemic. And thirdly, I just wanted to say, in terms of the model of how the environment should look like for these long-term care settings, due to the lack of neglect for these buildings not being updated, which allowed once COVID-19 got in, to spread very easily. We need to make sure that these facilities are very welcoming. And I'll just give an example of a particular facility, which is there's a facility in London, Ontario. It's called the Arbor Alzheimer facility. And it definitely provided a one-story courtyard setting. And it was set up very similar to a large home where everyone had their own room. And it was, since it was around a courtyard, everyone had access to the outdoor setting. But at least staff were trained, knew their resident, and felt empowered by this knowledge. And so lastly, I just want to again reiterate the fact that every resident needs to be the main piece of the puzzle, and they need to be at the table to ensure that they have a voice. And if they are unable to be at the table, then their essential family caregiver that will represent their voice needs to be acknowledged and ensure that they are not isolated and their voices are heard moving forward. Thank you so much for your time.
Thank you very much, Wendy, for your thoughtful remarks. We will move from Wendy to Wendy. So from a family to a person that during this entire pandemic has been really at the forefront of resolving issues, because I think Wendy is really has been resolving, including the outbreak, in a magnificent way. So Wendy, on to you.
Thank you, Doris, and just a few thank yous. I have a big task. I was told I need to speak for long-term care on the ground, which is almost impossible to do in 15 minutes, but I will do the best I can. I do want to thank RNAO. They have been a fantastic support of long-term care, especially through the pandemic, and of nurse practitioners as well. What you've done to support us is amazing. I am not the only leader that led our homes through outbreaks. It is a team approach. So I don't want anybody to think it's just me working away, because there's no way one person can do this. One thing I agree with Chief Justice Morocco about is that I too dread Doris's criticism. So I will try to behave and say the right thing.
You say what you need to say, darling.
And I guess what I heard you say that still makes me sad is that dread of having to move to long-term care, right? And I have worked in a long-term care home since I was 14 years old, all different roles, PSW, charge nurse, director of care, now an NP. I love long-term care. I think we do a fantastic job when given the right resources, and can provide people the care they need when they get there. I think we have moved the system to only admitting when people truly need to be admitted, when they do not function anymore. Do we improve their level of care? Definitely. You arrive at a long-term care home that functions well, we make people look really good. Their function improves, their cognition improves, their abilities improve, but I would argue that it is that support, that rounded support, that makes that happen. So we are not admitting people too soon. We are keeping people in the community, I think, much better than we did when I first started. People come in at higher complexity, for sure. What we haven't done is moved the staffing to support that. And I could speak all day about that, but I won't. That's the bottom line, is the staffing has not changed in all the years I have worked in long-term care. And I am gray now, so it is many years that I've been on the ground in long-term care. As a nurse practitioner, I've been a nurse practitioner now for 12 years. I went into my NP because I thought it was a great role for nurse practitioners in long-term care. Unfortunately, there were no jobs in long-term care when I came out. So I was lucky, I did have some experience in acute care as a geriatric NP, and then in a primary care setting for about 8.5 years. And they soon figured out my niche was geriatrics, and they used me to their fullest in primary care, and I think was a fantastic role there. I got one of the attending NP roles then about 4 or 5 years ago. Well, it's 5 years in May. And I think that's what kind of led us to do well in our homes. I had been in the homes for about 4.5 years, had developed a trusting relationship with the physicians I work with the staff that work there, with the families, with the residents. So we were able to navigate through COVID awfully, as everybody else did, but at least navigated with fairly reasonable outcomes. The one home, we've had multiple outbreaks that have never spread to residents, which has been fantastic. And the other home, we went into outbreak March 31st of last year. We were the first wave before even staff were wearing masks. We did have 7 residents. 4 of those 7, oh no, 6 residents, 4 of those 7 died. 4 of the 6 died, and it was awful. We lost 30% of our staff in one foul swoop. Yeah, fortunately we did not have to call the Army in, but that was because of some fantastic dedicated staff, including management and our nursing students, to be honest. And congratulations, RNAO, you will get many more very good RNs coming in, because those nursing students have really stepped up in long-term care homes to support, and especially that first wave. So I'm going to go.
And I will steal a minute, because I think you and Justice Morocco will enjoy this. Our board is putting a resolution to the AGM of making mandatory a placement in long-term care for undergraduate students. So that's coming at the AGM, and we're going to push it. It's the best place where you can learn really the care of complex older persons.
Yes, I agree completely. And Wendy, appreciate your comments. And we missed families terribly. Our arms were cut off, I felt, and legs, because of your absence in our homes. And those first months were awful without you. I think we have learned, and we put things in place that families can be in, although it's still not great, right? Like, sorry, you've got 8 children, only 2 of you can be essential caregivers. So it's not perfect. We still need to move on our ability to visit and get back to some sense of normal. I'm going to just highlight quickly the things that I think saved us through our outbreak in terms of what happened. And the one thing is that I think actually long-term care typically does not do outbreaks badly. We've been through many outbreaks. COVID was just a new beast for all of us. So we unfortunately took the brunt of that first kind of wave of new virus. We weren't sure what it was going to do, but I can tell you our health units, the way they supported us through my further outbreaks was like night and day from the first one. We were all just on the ground trying to figure it out through that first wave. So we definitely have learned with infection control, and it needs to be embedded always. And I pray that we have learned that and it will go forward. Wendy also mentioned the facility piece of it, which was the other thing that saved us. Both of my homes had been renovated. We've got mostly private rooms. We're all ground level, so at least we could do window visits. At least we could isolate people the way they needed to be, but that needs to be a standard across homes for sure. I was in the building, which I don't want to speak to me personally, but an NP being present. I don't know how homes got through it without, because the physicians did not show up. And that's, I'm not being angry, I'm just being blunt. Nobody showed up the first wave. If I use one word, it was abandoned, is what we felt. Respiratory therapists didn't come, physiotherapists didn't come, chaplains didn't come, doctors didn't come. It was nursing, housekeeping, dietary, and like I said, 30% less of us came. So all of a sudden we had like zero support. So as a nurse practitioner, I functioned as a PSW often because they needed a lot of help. I functioned as an RN because I would write my orders as a nurse practitioner, physician, and then I would process my orders because the pharmacies also pulled back in terms of their support. So we just really, and we had to change our entire process because we worked in group settings. That's how we managed care. All of a sudden, everybody had to be in their rooms, which is we're definitely not staffed for. So anyhow, I think every home should have an NP, must. That's just a push. And then the other thing that saved us was our strong, dedicated staff, both management, which you need, strong management, and then a core dedicated group. So I work in 2 small rural homes. So we look after our own, which I think helps where I am. But then you don't have a lot of extras to pull on either. And that's everybody. That was housekeeping, dietary, nursing, rec, everybody. So I don't know how much longer you want me to talk. Have I talked for 15 minutes? Because I could keep talking.
I think that's good for now, Wendy. So we allow the other people, and then we allow ample time for questions. Thank you so much. Donna, I think on to you for like 10, 12 minutes, and then Shirley. Then we will open for questions for Justice Morocco and for all of the panelists. Thank you.
Great. Thank you, Doris. And thank you, RNAO, for this opportunity. And thank you, Justice Morocco and commissioners and your staff for all that you've done. I'm looking forward to reading your 300 pages, and really I'm grateful for the opportunity to contribute as well as an association on behalf of our members. And I do want to thank the Wendy's for your voices and for shining a light. We recognize not everybody has an appreciation for what it really was like on the ground. And it was harrowing. We went into the pandemic. We'd already warned the government. Actually, we said we were facing a perfect storm. And I don't think any of us appreciated just how hard it was going to hit us. All of the, in the beginning, the whole focus was on hospitals, not on long-term care. And we were in the position when the pandemic hit, actually where we are today, where it's all about how long-term care is going to take people out of hospitals and be the solution to the hospital pressures. And I would say that as we looked at the root causes, the buildings, three and four people in a room, critical staffing shortage, especially of our nurses and nurse practitioners, RPNs. We weren't equipped, none of us, and I would say this is a global issue, not just Ontario, none of us were prepared for the virulence of this disease. So our infection prevention and control practices, which could stabilize us during a flu outbreak, just were no match, and our facilities were no match, and our staffing situation was no match for what hit us on the ground in our homes, especially in the first wave when we were facing asymptomatic spread. There was, and this just to echo Justice Morocco's comments, we were siloed. There was no recognition about the clinical care needs of our residents, the heaviness of the work, the fact that our staffing models had not adjusted or adapted to what the care needs are of our residents. There's a real structural problem in the broader system, but a structural problem in long-term care. We're built around a piece of legislation. We're built around funding envelopes and old buildings where it's a catch-all for everybody, for however they present. We'll just move everybody into this cookie cutter box. And we're not built around people. We are not built around the needs of our resident population. And the way we've certainly seen government respond, they can focus on one piece. So today we're back on hospitals. So put everything back into long-term care with no recognition that our front line, and so many of you, and thank you for sharing your passion, Wendy, there's no appreciation for what our nurses have been through. There is no appreciation for the fact that 14 months later, those who've been working in long-term care, your mental health and resilience is much diminished. Those of you who came from hospitals to help in long-term care and are now facing this next wave in hospital, your resilience is diminished. And we put a lot on you on our front lines, and we have very high expectations. So what we're seeing is a lack of empathy, quite honestly, and a lack of compassion for what our front lines have been through. We call you heroes, but yet what are those other pieces? And we really do need to be building out that structured continuum of care. Wendy, you spoke about reimagining what long-term care is. It is a big catch-all for everything. Imagine if we could build out something around the people we serve and build out our competencies around that, from independence at home, to home care supporting people aging in place, to much more differentiated programming, assisted living. What does respite look like? Day programming. Our population of seniors today is not going to age the same way that certainly my grandparents or my parents aged. They're not going to accept what we've just been through. And we are hearing, I think the public is going to have a voice in this, and we are going to have to be a lot more creative in this moment of disruption. The staffing situation is critical, and what we're seeing right now in long-term care is we're having nurses retire from hospitals, and we are losing our regulated health professionals from long-term care to hospitals, but also we're losing them to other sectors. So now that you have testing and vaccines and vaccination clinics and infection prevention and control, we are losing our nurses, quite honestly, to other sectors, including film and television, including education, including to airports, including to Amazon. So this really is a profound moment where the traditional career paths have changed. And however long that will continue, I think will remains to be seen. But how we educate and train and credential our nurses and how we share those resources is going to be profoundly important for us. So as we're looking at it and trying to support our members as homes, is we really want to think about where and how can we fit in the system in a way that is built around the people that we serve. And Justice Morocco, you talked about integration. By definition, a system is also built on interdependence. So how do we foster that interdependence? How do we determine, how do we use the scarce resources? How do we use NPs? And Doris, thank you for your advocacy around NPs in long-term care. Early on in the first wave, we were hearing people talk about how we needed to have 24/7 physicians in long-term care. There are communities that have no physicians. So how can we be more creative in using the role of nurse practitioners in our homes? How do we think about what those connections are with primary care and hospital acute care, but make it about the people, not about the structures? And certainly what we are advocating for is let's move away from hospital centricity. Again, how do we make sure that we're getting people cared for in the environment that they need to be? And let's think creatively about the economics of it. Let's think about the tone and approach of it. And let's make sure that we are building services around people and how they live. And I think that's really important, as the two Wendy's talked about, really reimagining some of these other pieces, but making long-term care a place where it's okay to go. It's part of your continuum of aging and care. Let's make sure that it's a place people want to work. And let's make sure that we're building out more interprofessional team models, and we're validating and valuing the work that is happening in our homes. And let's also, I think to the other Wendy's point, let's not lose what we've gained in terms of the recognition of the role of essential family caregivers. Let's not lose the infection prevention and control measures that are now in place and enhance those. Let's not medicalize it. Let's make it about people, but let's not lose those. We're very encouraged. Government is moving forward with redevelopments. We have new home opening next week for one of our members. We're very excited about that. We're very excited about the progress around virtual care and digitally enabled supports. I think those are profound things that we don't want to lose. We've got to really embrace vaccines. They're working. We're seeing that in long-term care. We're stabilized, but we still have a lot of work to do, especially on the HR front. That is the most critical piece for us. And where we're concerned as we're going through this wave is how are we going to, we want to help hospitals where and how we can, but we have to make sure that we're doing it safely and that we have the right staff, that we have the clinical capacity to support the care needs of those who would be transitioned. And we're going to have to be creative. So the traditional processes and timelines around processes really are not built for wartime. And so I think what we would love to do is use this as a moment for major disruptive change. Let's embrace the opportunities that we have today and continue to work together. I would argue too, and to Doris's point around collaboration, what's come out of this has been some really, truly remarkable partnerships. OLTCA is working closely with Advantage. We're working very closely with our family councils and our resident councils and other senior advocates, with RNAO, with the OMA, the Ontario Hospital Association, and we can't lose these partnerships. And I would argue too that it's incumbent on us and as you as individuals, we as associations, but you as individuals, to problem solve. As somebody who's spent the better part of my career in around government, looking to government for the solution is not going to work. So here is our moment, and here is our opportunity to give government the solutions that we can co-create together. And the kind of collaboration and partnership and shared vision for doing something different, I think it's there among us. And so how do we then make sure that we continue to challenge government and not accept anything less than what our people actually deserve, you as professionals, but also as our family members. Let's challenge them to say, no, that isn't actually going to work, and work through. Where we felt challenged, quite honestly, over the last 14 months is government brings forward a directive and it's completely inoperable. You can't make it work. And that comes because they don't know what it's like on the front line. They don't know what it's like to work in a long-term care home. They don't have an appreciation for what it's really like to do home care. And so this is our moment to educate, to shape, to make sure that we come together. So I'm so excited to be here today because I think this is really important. I think the only other piece that I would really emphasize, because my other life has been as a mental health advocate, having worked both at CAMH and run a large children's mental health agency over the years. The fact that for me, long-term care has come to the fore, and we now have recognition about what our challenges are and recognition of that perfect storm, to have that in tandem with a recognition of the need to talk about mental health issues, to start to build out those resources and invest in that for our residents, for our families, and most importantly, for our front line. So it's been a moment where these things have converged, and I have to tell you that I think it's an important moment for that as well. And so thank you for all that you have done and continue to do. We will continue to advocate with Doris on your behalf and on behalf of the people that you serve. So thank you very much.
Thank you, Donna. And I want to echo, I wrote in the comments that to me, one of the biggest silver linings of this pandemic has been partnerships. Both with associations and also with individuals that, quite frankly, otherwise I don't think I never would have crossed the same path, because, you know, some of the top epidemiologists, it's just partnerships, really. I mean, people have been generous in partnering, generous in wanting to do good. And this is the silver lining. This is also the frustration, because we have advised, because we have begged home cares. You will hear from Shirley. We have begged with home care to do vaccination, for example, because we want to do more. You heard from Sally in the previous presentation to Matt, please redeploy the care coordinators. Like, people want to do more. And I think we need to just throw the doors open and let people contribute what we are all able to contribute, and fix not only the pandemic, which is bringing us to our knees, but fix really the health system for the go forward. Shirley, yours, and then we will open for questions. Commissioner Morocco, I think you are getting another focus group here. So, you know, we had arranged, you are on mute, we had arranged that he will present and then will be questions. And all of a sudden I thought, given the presentation and how he led the presentation, and the example about his mother, which again I say was beautiful, that I thought you all can pitch in and build into his report, and then we open to questions to everybody. So I hope you didn't mind the change. I apologize if I misstep on that.
No, not all. I am making notes, so.
Thank you. Shirley, all yours. Shirley, the grandma.
Yeah, thank you very much, Doris. And before I get into the elephant slide, just a couple of things. One, many years ago when I was actually president of RNAO, believe it or not, Doris, that was in 2000 and 2002. I just looked it up. I was so proud to be affiliated with such an amazing thought leadership group of wonderful nurses. Now, 2021, and with all we've been through with COVID, I'm not only proud of the thought leadership, but the courage. And the courage, Doris, starting from you at the top, and all of us as leaders working with your leadership to help us move forward with all of the changes that we're talking about. So a very personal thank you and a very collective thank you to everyone and to all of us as we care so much about individuals and our staff and our clients and families. Also, Wendy, to you, I do very much love the word that you used, which was love, and love long-term care. And for me also personally, I have loved where we're able to bring hope and happiness to people where they live their lives. And that's a very different way to describe what we are all about as nurses or health professionals in the healthcare system. But at the end of the day, and Justice Morocco, when you talked about your mother, that's what it is all about. Our love for people, our desire to have them remain hopeful and happy in all of our environments, and in particular our healthcare system. The only other thing I will add, Justice Morocco, is with all due respect, I am not looking forward to reading another report that is hundreds of pages long. And I am, though, however, looking forward that we actually move on the suggestions and recommendations and bring them into policy and funding. And that it has been, for me in particular, 3 decades of reports about care for the elderly, about the long-term care system, about home care. And one would hope that we do move forward with action and move away from reports as we continue to sometimes get focused on those. Now to the elephant, now to the fun part of the conversation. I was trying to give some thought to how we have great difficulty understanding 2 aspects of our system, the whole system and the whole person. And I was thinking about what's an analogy that I could use of why, in fact, when we look at long-term care homes, when we look at hospitals, when we look at home care, it's fragmented. And this is, of course, as some of you remember, it's an ancient story of a group of blind men who were trying to learn and conceptualize what the elephant is by touching it. Each blind man feels a different part of the elephant's body, but only a part, a side, a tusk. And then from there, they describe the elephant based on their limited experience and their descriptions of the elephant. And they're very different from each other because of what they have touched. So I think the key takeaways as we look at our healthcare system is that actually we all have limited perspective, which means we have a partial perspective. Our view of reality is based on our own perspective and our experience. To understand the big picture, we actually need to make sure we're including everyone's perspective. And I know very much so from RNAO's perspective, the patient, the client, and the family is also paramount to understand that view. Because I do think we actually have, and you can take out the elephant now, that there is an elephant in the room, both literally and figuratively, because we've been trying to pivot our healthcare system to meet the needs of an aging population now for decades. Yet we continue to fall into the trap of what I would call blinkered or myopic thinking, where we approach problems and solutions in limited and partial ways. And let me give you 3 or 4 examples just in the last year with COVID. Certainly, looking at long-term care, even our definition is limited. Just as we have talked today, it's sometimes about a collection of facilities versus a system of care. A system of care, and we've talked about this, this is where people actually want to live in their homes or however they may describe their home. And they want to live there, they want to age there, they want to die there. 65% of people still die in the hospital, when well over probably 90% want to die in their homes, however they describe those homes. And we still see 90% of funding for seniors care is in institutions and in hospital care, only 10% in the community, compared to OECD countries where it's 35%. The ECHO model that RNAO has been trying to put in place now, how long, Doris? How many years?
Since 2012, the first iteration 2012, then again 2014, then on May of 2020 during the pandemic, and we said it needs to happen now, and it integrated also LTC into OHTs at the time, which of course has not happened. So yeah, and all the reshaping, rebalancing to community care.
Yeah, and what that would mean is probably 35% of the resources would be going into the community, which is what many other international countries are all about. And I don't mean home care, I mean in the community. I mean primary health care, I mean community supports, I mean services for people in their home. And that's what the ECHO model is all about. It's a broader way to look at and maintaining people actually where they want to be, which is in their home, doing well, managing their conditions, and accessing care how and where they need to. However, let's just talk about what's been happening in the last year. Wave 1, thousands of ALC patients, we've heard about this, were discharged to long-term care and all of the challenges that took place there. Home care, actually initially about 30 to maybe 70% of our volumes were cut back, shut down. Can you imagine that? When everything else was about stay at home, we actually shut down home care services.
And Shirley, we also almost shut down primary care. Right?
Absolutely, that's correct, Doris.
Yeah, so yeah, the opposite that the countries that did well actually did.
And rather than have people in the hospital environment be discharged, some home, some to long-term care, it was the continued default of independent of conditions and a variety of other supports. And because of decades of under-resourcing, they moved into the long-term care. We've heard a lot about the challenges, the despair, and the difficulty with that. I think secondly, another example, and we've heard a lot about this with resourcing long-term care, hours of care support, which is critical and fundamental based on the populations that exist there. But again, without a systems approach, we totally destabilize the health human resources that we need for the entire system. So we need to certainly invest, but we have to look back and go, what are the consequences and where else do we need to invest? To build on long-term care and funding and support, home care has had no increased funding in our rates and visits and model of care for well over 15 years. Again, the same concept of what do we value, what is important, what are we trying to do for people, and what do people want seems to be opposite with where we're putting policy and resources. Again, now, as we are looking at hospitals and getting people out, a systems approach would be, how do we prevent them from getting there in the first place? How do we shorten the hospital stays and get them back into the community as fast as they can so that they don't deteriorate? And then thirdly, of course, how do we move them into long-term care if in fact that's the right desire that their family and the individual is looking for and what their care requirements are. from a whole person point of view, that's sort of the whole system. I think more and more with our care as nurses, and this is where I think we're so well positioned to understand that healthcare is actually about life care for people. It's actually not chronic care or long-term care or the silos or the positions, but we understand that it's life care for people, how they're coping with their illness, the interventions that are required, and the supports from a whole, let's call it ecosystem of what we need to live our lives. And nurses can understand that best, certainly from not only the clinical and the pathological interventions and what needs to happen, but also from the life care and also the joy and involvement and hopefulness and happiness, all of that component that we bring into the experience with people. What we certainly are finding with both long-term care and home care is that the population of people and their needs are very similar. And actually with a research review that SE Health and the University of Waterloo were working on with Interrai and with John Hurdy's, here's some interesting fact. They reviewed over 200,000 home care assessments. 80% of people living at home, about 162,000, they were considered at risk for long-term care placement based on their medical, psychosocial, cognitive, functional indicators, etc. And the thinking is, if we can provide the kinds of support that they need, then the timing and when they move into long-term care could be very, very different. And the trajectory now of you're sick, you go into the hospital, you default to long-term care, needs to change up so that all aspects of our system, long-term care, home care, and acute care, and how people are managed and are able to get access to care in the community is a very different experience. Right now, especially with the aging population, as we know, it moves very quickly into ER visit, hospital admission, and then into a long-term care facility. And we have to change the trajectory of that and reinforce the supports that are needed in every aspect. Now, as we've talked, a big component of that is making sure that we actually have the talent that is valued, recognized, and supported in every aspect of our system. A nurse is a nurse is a nurse, whether in home care, long-term care, hospitals, etc. We have to stop moving employment to where better compensation exists, which really means we're valuing people in a different way depending where they happen to be located. And that's where much of the policy and the funding needs to change and be implemented. And yes, the reports, and this is probably now in my 30 years, maybe we've had 20 reports plus. Andre Picard, in a couple of his articles and in his book, talked about
35, Shirley.
How much?
In Ontario alone, 35, in the country about 120.
Yeah, back in 2008, I worked on a report, People Caring for People, with Tazim Varani, who I think is on the site, who's another real RNAO supporter and an amazing, talented nursing leader. And believe it or not, the big surprise, we came up with the fact that there needed to be more resourcing in long-term care, that over time we needed to look at 4 hours of care. We talked about the role of registered nurses in the facility, the same common themes that continue. So I am hopeful that now we really will move to policy and to action. And I think it will take all of us. It will take a village, all of us, to really push forward with changes that are needed, not just in long-term care, but I would say in our entire health system. As much as I am very committed to the home care space, I truly believe shifting things to primary health care and to where people live in the community and give them the robust solutions that they're looking for will meet the needs of what people want. which is stay and live in their homes. And then we will create the other alternatives, long-term care, institutional care, and the need to go to acute hospitals. They will also remain and be robust and be supported appropriately. And this is why we really need a whole multi-pronged approach. So quite frankly, we never experience what we did in the last year with the number of deaths that have occurred with our elder population and the heartbreak that has occurred with all of our family members and with society, and that we truly create a Canadian system that we're all proud of, and that we in fact become leaders internationally, because right now, from care for the elder and seniors, we are not. And I really reinforce a lot of RNAO's positioning of use evidence, use best practice, implement the eco model, and move forward with the changes that are really necessary. We don't need any more reports. And I do say that, Justice Morocco, with the greatest of respect for the work that has been done. But also I say that with the greatest passion that we have to get moving. And maybe it's just that on a personal level, I'm getting older too. So I want to make sure we have a great system for myself personally, but to circle it right back, I want to make sure, Doris, that my granddaughter has an amazing Canadian health system that she can be so proud of. And that's what's the most important thing for all of us.
So I thank you, Shirley, and thank you to all the panelists and to Justice Morocco. And it's interesting you brought it full circle to apologize to Frank for our impatience, for our, there is a difference between then and now. There is a difference between the 35 previous report and this one. And it's not only on RNAO, it's on the public. There will be a revolt. And I think Frank leverage on that. There will be a revolt if whoever is the government of the day, current, future, and we will make sure that we are part of that revolt, RNAO, because we ain't going to ease the pressure on whoever is the government of the day to fix the mess. And I'm talking provincial and I'm talking federal. Yesterday I was in touch. It took us 2 days to put the press release. Finally, we are putting it out. There will be a revolt because what happened in Canada is unfathomable in a country as rich as ours, with the talent that you hear today and you hear every day, and you heard that in the people that came to speak with you, Frank, with the passion of people wanting to do better and more. There is nothing short than a revolt if whoever is the government of the day, provincial and federal, don't fix the problem with us, not for us, with us. And I know that Donna and Lisa and all the others will be part of that revolt because seniors deserve better. They deserve better in the community and they deserve better in nursing homes. So I guess the first question is from me to you, Frank. Do you think that to this point, the interim letters that you put, in addition to inspiring us, because that's what changed my view, certainly on RNAO, have actually made an impact so far? Because, you know, it was last February the 1st, if I recall, you know, so a long time already, previous February, right? So do you think, and as much as you can comment or not, tell us if you can, are you hopeful that this time will be different than the previous 35 reports, counting with our revolution, which we will create if there is a need? You're on mute, Frank. Thank you.
I always forget. I'm sorry.
No worries.
I became aware pretty early on about how many different reports there had been. And I remember when the deputy minister we were interviewing him, and he talked about studying studying the staffing study, that that's what prompted the comment in our report about the time. And I think, if you recall, it is no more time for studies.
Yep.
But did the interim reports make a difference? I don't know. I think with the staffing study and with decanting, maybe adding our voice to your voices and to the voices of others maybe was helpful. The way I look at this problem of how do you get past the study stage, we're all sophisticated enough to know that sometimes when they decide to study a problem, it's because they intend to do nothing, and they don't want to say that they're doing nothing, so they say they're studying it some more. We all get that. I'm not sure it's always appreciated by others how quickly we get that, but that's a reality. So I thought that in issuing an interim report, we were adding our voice to yours. We're a little different though, because we were asked by government to do this, and we're doing it. So it's like saying to them, these are your own people. And how do we get past reports? I do have a strategy, actually, and I'll share it with you. I think when we release our report and you all look at it, you'll have to decide whether you can support it or not. But let's assume you can. Then I think it's useful for our report to become a focal point, because we were asked to do this. We do not have an interest in any particular segment here. I did not put up my hand. They called me. I didn't call them. I wasn't looking for a job. So this is the report that your own people produced. And I say, if after you read it, you find it satisfactory, then I think the strategy is to say, implement the thing. Let me get, oh, thank goodness, my wife answered the phone. Usually it's the air vent, the air duct people. They call me almost every day. And I don't have, anyway, I'll spare you that. But I think then there's a focal point for people's pressure, and it's not their own. It's something that the government did for itself, and the strategy is then to keep the conversation around the implementation of it, and don't let somebody get distracted by. And I was listening when Shirley was talking. You know, everybody has it. Everybody believes in this, or you wouldn't be spending your lives doing it, or spending your lives being interested in it. It's easy to get people like that to reimagine the system, and there's nothing wrong with that. There's nothing wrong with taking one day, and talking about that. But that isn't good enough, because there's things that need to be done. So I think that that's the strategy that might work, and hopefully put an end to the endless reporting, is if you can get behind one position and then advocate for that position, then maybe it makes sense. Now, if people don't like our report, well, then you're not going to advocate for it. But if you do, we do provide an opportunity, because we were called into existence to do this very thing. So So do I think our reports made a difference? Well, I'm kind of prejudiced because it was our report, but I think it might have helped a little bit with the staffing study and the decision to announce its implementation, albeit over too long, perhaps a period of time. But nevertheless, maybe with that and maybe increased some sensitivity over decanting. You know, I remember one of the witness. I don't want to talk too long. I'm sorry if I am.
That's okay.
I remember one of the witnesses saying, "Oh well, it's very disruptive moving people." Well, ask them. Do you want to stay here, or do you want to be moved to a place where we think we can separate you from this virus? Ask the individual if they are not capable of answering. Ask the substitute decision maker. What do you want to do? I suspect. I mean, I don't know. Maybe I suspect most people would say, if I'm not safe here, if there's a real concern that I'm not safe here, yeah, I'll go. Or you can move my mother. I'll go speak to her and try to explain it to her. But anyway, that's where I think we might have had a little bit of an impact.
Thank you. I know we will continue to be in touch, as I continue to be in touch with Justice Galice. She too wants her report to be implemented. Some of the pieces, I'm sure you know it thoroughly. So let's hope that this time is different. Let's say this from an RNO perspective, and the 46,000 plus many others now that work with us. We are not going to let a day go by without putting the mirror in front of those that need to answer with actions and with funding, and to be able to really make a difference for the tragedy that took place, because it is a tragedy.
Doris, would you mind if there was one other thing I wanted to say, and that is that, you know, we live in a democracy where we call upon the current minister to answer for the situation, regardless of what it is. But I think it's productive in this situation to emphasize the fact that these problems are long-standing problems, and there are this is not the specific minister has to answer, but these problems existed over a long period of time. I think that's an important part of the discussion, because I think if the discussion comes out that, well, it's all on whoever happens to be the minister at the given moment, they get defensive.
Of course.
And they said, look, I wasn't here 12 years ago.
And RNO has been very strategic about that, and because it's fair. Nonetheless, the current government is 2 years in place already. They cannot say we inherited.
No, it wasn't a defense it was just that I think that it's a fair way of putting it. We want the problems that have been in existence for a long period of time solved by you now.
Yes, exactly. Yes, absolutely. Yes, absolutely. Yes. And the same goes for the federal government. I know that there are comments in Majin, maybe.
Yes. Okay, so maybe I will just summarize some of the comments. There's been such a rich discussion, as all of you have been speaking, and discussion that's related to, first of all, much more time for action, no more time for talking, please. Everybody has really resonated with that. A lot of discussion about the value of student rotations in BSCN programs in long-term care. That's well accepted. Much other discussion on NPs and some of their challenges in finding roles, given their backgrounds and experience, given funding, given a number of barriers, and it seems to be something that really needs to be addressed out there. there's two specific questions that I'll raise and leave it for whomever may wish to answer. The first is, what do you see the role of long-term care in the OHTs? How can they be included? And then the second question is questions about NPs as medical directors. And that did happen. Does it continue to happen? And will it continue to happen post-pandemic? So let's maybe start there with the OHT question.
If you want, Imogene and Shirley, I could start the conversation.
Sure. Yeah.
I think what's important with the OHTs is, again, the big prize is actually to create healthier populations, healthier communities. The focus is, how do we get every piece of the puzzle in healthcare provision working together, when actually it should be, how do we actually create the environment that gets the population health in those communities improving. I just start with that as a starting point, because then the issue isn't so much where does long-term care fit, it actually is where do people fit in these communities, in society, and then how does all of these aspects of primary care, living in their home, when they may need long-term care and acute, how does that all play out? It's a very different starting point. If we start with how to keep people functioning and where they want to be in their communities, and then we start to design the system differently, then it's less about where most OHTs are now starting, is the dominance of the hospital system, because it has power, resources, and a focus. And then where do we all line up from that power? And I am not convinced that that starting point will actually create healthy communities. So a lot of it, I would say the first start is, let's refocus the OHTs in general versus trying to have all of us, because the same question happens with us. Where does home care fit with the OHTs? Where does primary care fit with the OHTs? Where does long-term care fit? You can see how we're all going to be little pieces of this bigger acute medicalized structure that is critically important, yes, but it's a very different piece to keep the population healthy, and we're allowing it to be the dominant piece.
Donna, if I could just build on that. We tend in government to start with structures, and in our view, we really do need to recenter it to Shirley's point around what is the problem we're trying to solve for, and who are the people we are there to serve. And so taking a more of a principles approach as opposed to a structural approach, you know, we tend to really focus on the bricks and mortar of things, and the architecture of those buildings and their situation in the community. And what we often end up is like a really bad 1970s addition to the structure, where we're trying to put unnatural things on top of each other and together, as opposed to really reimagining it. But I do think that we can start incrementally to start to rebuild the foundation for something that's new, as opposed to just trying to force everything on the hospital structure as the hospital as a foundation. It's the highest price point. It's not built around people. It's built around their governance and their buildings. How do we reset that? And I would argue that through this, with the emergence of how we can use technology more effectively and efficiently, how we think about how we use our professional resources, our nurses, our psychiatrists, our specialists. This is a moment to rethink that. We are not going to build 150,000 long-term care beds for our aging population. And we've got to move away from process-driven or structural pieces to really taking a more holistic approach to build on these pieces and connect the dots. So let's make it more of a jigsaw puzzle as opposed to a game of Jenga, where we're trying to just put things on top of each other. And I think we can get there. I think we're all very like-minded, and there's such a coherence of thinking in this discussion today. It's remarkable how well aligned we are in terms of what needs to happen. And I think we just need to make sure that we challenge our decision makers and in how they approach things, and maybe do a reset coming out of this.
Okay, thank you, Donna. Now, I didn't know, Doris, if you wanted to make a comment on the medical director, and then there's a number of comments about BPGs I'd like to share, and staffing in long-term care.
Will, Irma Jean, I just am answering, I'm getting bombarded with direct messages from people. So people are asking me about the memo regarding transferring patients from hospital to long-term care. I put the entire council different memos there. Look at the memo from Matt Anderson. It speaks about 1,500 persons from hospitals to be moved to nursing home. Donna, you were CC'd, so was Lisa. I think you were the only one CC'd, the rest is government people. In any case, I am fortunate that the media, because they want my reactions on various things, they generously provide me with all the memos that are not necessarily always public. So that's there. Look at the memo from Matt Anderson directly, and that's why I asked him directly. In any case, on the issue of medical director, and we did speak with Justice Morocco when we met with him about this. As you know, many homes do not have a medical director for whatever reason. That's one piece of the equation. Second piece of the equation is that we succeeded on the previous government when Deb Matthews even was Minister of Health so long ago to negotiate for attending NPs in long-term care. The commitment to us or to RNO directly was 75 NPs in long-term care. In the last leg of the term of Kathleen Wynne, already we had 60, 15 were put on hold because was change of government. About a few months after, I was called by the government saying you will have the 15 now. I'm still waiting 2 years. We don't have those 15. Put all those together, and what happened during this pandemic, which lots could have been prevented if we indeed not only had, the 75 NPs in long-term care, but in fact, if we had what we are asking now, which is 1 NP per each long-term care. A lot could have been different. Wendy, thank you for being honest. Donna is well aware. We are all well aware that in many of the homes, the doctors didn't show up for whatever reasons. They were busy, probably. This is not their primary job. They were busy in their primary job. That's my take on it. It's not that they didn't want to show up. But then the primary job is long-term care. That's why we need 1 NP per long-term care. And that NP, in our view, and I know that NPs may criticize me, and I take ownership for that, that we said to Justice Morocco, they can function as NP, attending NPs, or they can function as medical director, or they can function as both, Because I think in many ways, because we need to look at the realities of funding, but equally important, in many instances, if that NP is medical director and attending NP because it's full-time in that home, I think things will get a lot better. Of course, we need the 4 hours that we speak in, the 4 working hours that we speak in the nursing home, basic care guarantee, but even best case scenario for RNO, that would take 2 years, 3 years. I think we can do it in 2 years. But then P, if we put, right away, and if we bring more people, and we are bringing more people into nursing, that I have the commitment from government in increase enrollment to their own programs, and that will happen as of this September. Then we can then start to fast track to the NP. role current RNs. I'm sure if the opportunity was there in nursing homes, same as in home care, and I know Shirley will not, for NPs to join the trenches of long-term care, they will run there. Nurses go, whether it's RNs, RPs, or RPNs, and we all know it, and quite frankly, even PSWs too, they go where there is a need. Nurses go where there is a need. You talk about the war, Frank. I work in a war. I know nurses go where there is a need. So we need to create opportunities and they will come. Of course, they will not come if the hospital is paying 120,000 and the long-term care is paying 90,000. This is why your comments about harmonizing upwards, same as for home care, regardless, RNs harmonize, RPNs harmonize, NPs harmonize, and let the people go where their passion and their expertise is and where the opportunities are created. And we need to do it urgently. If we want to fix long-term care, NPs to us is a main block that needs to be put, a main pillar that needs to be put first in place, because then when the RNs, the RPNs, and the PSWs will come, they will have that milieu, that mentorship, that teamwork that will be just fantastic.
I just want to say one comment, if I can, just around the NP physician piece. So I work with two fantastic physicians. They are bang up, they're dedicated to our homes. They were told in that first wave not to come in.
Yeah, I'm not
to come in. So it's not that they didn't want to show up, it's they were told not to show up. And I think the model of care, we need physicians in long-term care homes, right? I love being an NP, but I love and need my physician colleagues because I am not a doctor. And I tell people that all the time. So I really think we've got to keep a collaborative model going. We need our physicians in long-term care home, and they are showing up now. So they're back.
And let me just add to that, Dr. Grinspan, you spoke about NPs as a pillar in long-term care, and what I'm seeing in the chat coming through over and over is that BPGs should be a pillar in long-term care. And in fact, in many settings they are, and they really make a difference. And you mentioned NPs go where there's a need. Also, NPs and all staff go where there's excellence and quality and evidence-based practice. And I'm seeing various people mentioning specific guidelines that they have found useful. And absolutely, the RNAO BPGs are really what can be a lifeline in long-term care. I wanted to read out.
I need to apologize. As a founder of the program, I absolutely agree with you. I want to add to it, though, that also those homes that are best practice spotlight organizations perform better even during the pandemic, during the pandemic. And they use the person and family center care, and Shirley can talk to the moon on that too in home care. So thank you for reminding us of that.
Yeah. And there is a comment here, and then I'm noting our time. We need to wrap up. RNs and NPs, we could add, are so critical in our long-term care homes. While the focus has been on PSWs and greatly appreciated and badly needed, the registered staff and managers in many instances have been neglected. No pandemic pay, lower wages. One administrator was described as saying they're hearing a sucking sound from the office as registered staff leave, moving to other opportunities where they are appreciated. And I think the leadership and clinical skills of registered staff, including RNs and NPs, is really pivotal to safety and quality in long-term care. So Doris, I'll turn it over to you for our closing.
Thank you so very much. And Wendy, I want to make a correction. We are not saying, nor did we recommend to Justice Morocco to replace medical directors with NPs, but you and I know that there are many homes, and so does Justice Morocco, that simply cannot even secure a medical director. And MPs certainly in those homes will be a welcome addition. And they did it during the pandemic. Bottom line, they did it during the pandemic. So with that, I will actually ask Justice Morocco to do the closing remarks in terms of what you heard, in terms of how useful this was, and in terms of, I heard very loud and clear your advice, and it's noted, and it will be acted upon in terms of making accountable the current government of the day, whether it's now in a year or 2 or 3 years, but reminding people that we are 15 years drumming on this, and the time for action is now. So I leave it to you, and thank you to all the panelists, brilliant panelists, each one of you. Wendy, the two Wendys, Donna, Shirley, and back to you, Justice Morocco. Thank you.
Well, thank you. If you were asking me to have the last word, I learned something listening to the conversation. I seem to learn something every time I take part in or get or interact with the association. Part of it reinforces too certain ideas I have. I was struck by the idea that so many people see it the same way. It's funny that it's so hard to bring about, and I very much did take your point the first time that you weren't seeking to replace medical directors, but that there is a role for the nurse practitioner that's maybe not been fully utilized, I guess the best way to put it. I did get that. But I just, for me, I thank you very much for just being able to listen to what you all had to say. It's just very, very helpful. And I guess, Doris, this was a big focus group. I didn't know I was attending one, but it was very much to my benefit. And thank you very much for the invitation and for the opportunity to learn something.
And now that you disclose where you live, you are in big trouble, because as soon as this pandemic is over, we are going to meet for coffee to see, did anything change a year from now, 2 years from now, 3 years from now? And hopefully we will be able to say yes, on behalf of all the colleagues that have really worked in the front lines, my colleagues, RNs and Ps, OLTC, Advantage Ontario, and also on behalf of the patients, the people we lost, too many. One would have been too many. Certainly almost 4,000 was way too many. And the families that are left in anguish, and the next journey that is still ahead of us. So we will rebuild together, and I'm sure your report will support us coalescing on some of the aspects that we need to move forward. Thank you so very much, everyone.
Thank you.
Thank you.